Hello everyone, I am Dr. Sandeep Sharma and I welcome you to the discussion of Test and Evaluation Program paper number 2. In this paper, you must have taken the exam, and if not, and if you are directly jumping to the video discussion, this discussion deals with the paper number 2 where I have covered inborn errors of metabolism, rheumatology and immunology. Let me tell you a fact before we start. Inborn errors of metabolism is the rank decider. Let me tell you this again. Inborn errors of metabolism is often the rank decider. The only exception was in the previous NEET SS exam, a bit of atypical and a lot of cardiology was asked. But if you keep that aside, traditionally, this is the rank decider. Why do I say so? Because questions are asked in good numbers. Topics are those which are generally not done well, and these are the patients you will not see them well when you are dealing in your clinics. And finally, Nelson has a lot of updates on this. Nelson has a lot of information on this, and many times we are not very sure which information is really useful for the exam. So if you are a subscriber of PrepLadder SS, I have done the detailed videos. I have also covered a lot of these topics, including the new Nelson updates in the rapid revision part. But here I am going to take up another aspect. I will be taking up some actual NEET SS questions also as a part of the previous year questions, of course, based upon recall 2022. Similar questions I will be taking up in this session. As is the norm, before we start with the discussion, there are some topics from IEM, from rheumatology, from immunology, which you must see. First of all, galactosemia and GSDs are important. GSD is glycogen storage disease. Phenylalanine metabolism defects, phenylketonuria, alkaptonuria, tyrosinemias, Hawkins-urea, very important. Hartnup disease, mucopolysaccharidosis, urea cycle defects, and organic acidemias. Then progeria is important. I have discussed progeria as a detailed video. Gaucher's disease, Niemann-Pick disease, Tay-Sachs disease, Sandhoff, and GM1 gangliosidosis. Then in rheumatology, you have neonatal SLE. The entire SLE is important, but neonatal SLE is one of the favorite of examiners. Then Kawasaki disease and Henoch-Schwann and purpura, JDM, JIA, and especially Sogia and MAS. These are the topics which are frequently asked in NEET SS as well as INI-SS. Then we have Dijor syndrome and complement defects. Finally, broad approach to PIDs, which one you have Candida infection, where you have Giardia infection, all infections, where staph infection is more, BCG vaccination causing problem. So those kind of broad approaches. Then SCID, CGD, LAD, new chapters in Nelson 22nd edition. There are some new chapters. We have already covered in the detailed videos in the new edition. And lastly, vaccine scenarios and open vial policy. I don't know why, but open vial policy is one of the favorites of not just NEET SS but also INI SS examiners. With this in background, let us start with the actual discussion. Let us look at question number 1 of paper number 2. Question number 1 says, a 9-month-old boy presented to OPD with complaints of delayed development, hypotonia, depressed nasal bridge and failure to thrive. His abnormal hair is as shown in the photograph. Which of the following is true? Now, let us analyze the information. Whenever you get a question, always analyze the information available. Question is saying delayed development, hypotonia means there is neurological problem. So, neurological problem is starting before 1 year of age in a boy. Okay? It may be X-linked recessive, we are not sure. It may be X-linked recessive. There is depressed nasal bridge, which means there is a bit of facial dysmorphism, and failure to thrive means that it is affecting the entire body. His abnormal hair is as shown. Now, abnormal hair, as you can see, it is hypopigmented hair which is there. And it is a very sparse hair. You can also see some, broad patchy alopecia also developing in the child. This type of hair is called as the so-called kinky hair. And so, neurological problem, male child, kinky hair, failure to thrive, facial dysmorphism, everything fitting into the diagnosis of Menkes disease. So, the child is suffering from the diagnosis of Menkes disease, also called as Menkes kinky hair syndrome. Keeping that in mind, let us look at the options. Which of the following is true? ATP7B gene mutation, wrong. Menkes disease occurs because of ATP7A gene mutation. Is there high total body copper stores? Wrong. Total body copper stores are low. Rarely they may be normal in a few variants. Then hair microscopy shows trichorexis nodosa. That is the correct answer. Hair microscopy shows that the hair has micro fractures, and when you try to pull, it tends to break easily. This condition is called as trichorexis nodosa, and Menkes disease, one of the important causes for trichorexis nodosa. Already we know the answer, but look at option number D also. Copper histidine improves patient if started beyond 1 year of age. Wrong. They should be started as soon as possible, preferably within first 2 to 3 months. So D is not the answer. So what is the answer to your question? C is your correct answer. So this was a question which we created for this exam. Also, this photograph as a different case scenario, but the answer was same. Menkes disease has already been asked in NEET Super Speciality 2022 as well as NEET Super Speciality 2023. So it's a high yielding topic, Menkes disease. Let us have a look at brief review of the topic. So quick review, Menkes disease. You can see on the side, this is what you call as trichorexis nodosa. They show this photograph. This is here microscopic appearance of trichorexis nodosa. Now, what is the other name of Menkes disease? It is also known as trichopoliodystrophy. So, trichopoliodystrophy is the other name for Menkes disease. What is the inheritance and gene? These patients have ATP7A gene mutation. It's a ATPase dependent gene which is responsible for copper transport. This is responsible for copper transport from the gut epithelial cells into the systemic circulation and into the tissues. Now, if there is a mutation in this gene, copper will be absorbed from the gut. And in fact, the absorption is very efficient. But this copper cannot reach the circulation efficiently and it cannot enter the tissues sufficiently. And particularly CNS entry is affected, leading to neurological problems. And what is the inheritance seen in the patient? It shows X-linked recessive inheritance. And that is why it is commonly seen in boys. So boys are predominantly affected, girls are only carriers. Now, what are the involvement features? Key points, let us review them fastly. CNS involvement will be in the form of developmental delay. There can be seizures and there can be microcephaly. Some children can go on to develop decreased tone, that is hypotonia also. Second is skin and hair involvement. Skin in these patients is coarse, and hair is in these children, it is hypopigmented, it is curly, it is silver wire like, and there is increased risk of developing alopecia also. Third, facial dysmorphism is seen. These children have abnormally, according to Nelson also, they have abnormally chubby cheeks. But they also have saddle nose appearance. So this gives a very peculiar facial expression to these children. They also have failure to thrive, so poor gain of weight and height is also present. What about the screening test? Earlier, we used to do a test known as lysyl oxidase activity test, but it is not a very sensitive test, so it is virtually discarded. There is another test. It's not a screening test, but some of the literature, not Nelson, but other literature, other review articles talk about it. There is a calculation of a ratio that we do, urine HbA by VMA ratio. That ratio becomes abnormal in Menkes disease. Again, it's not a screening test, but they can ask you abnormality of urine HbA by VMA ratio is suggestive of which patient? It is suggestive of Menkes disease. And coming to treatment in the patient, the treatment is always copper histidine complexes. And these copper histidine complexes must be started. They are given as intramuscular injections, and these must be started, although oral preparations have also been tried. So they must be started within first 2 to 3 months of age. So this is Menkes disease. Generally, it doesn't have a very good outcome. Moving to question number 2. And this question, dear friends, is also NEET Super Speciality 2022 MCQ, very similar to NEET SS exam. Now, which among the following can be used to make a molecular diagnosis of methylmalonic acidemia? Methylmalonic acidemia is what we are talking about. Methylmalonic acidemia, also called as MMA, it is a type of organic acidemia. So they are asking you, what is the molecular diagnosis? How would you make the diagnosis? Common sense, let us apply. Methylmalonic acidemia is caused due to multiple somatic gene mutations and polymorphism. So obviously, karyotyping is not going to be useful in these patients. So karyotyping will not be the answer. Reason? Karyotyping is more useful for aneuploidy screening, where there is an aberrant number of chromosomes. So it will not be much useful here. Because the number of genes are too many, individual gene sequencing is also not an option because there are so many genes involved. I will be telling all those genes all those genes are involved, and so individual gene sequencing becomes very messy. Now we are left with A and D. The correct answer to this question is D. What is WES? WES stands for whole exome sequencing. Whole exome sequencing. When this question was asked, I interacted with some students in my groups, in my social media groups, and some of the students said, "Sir, we did not even know WES full form." I said, that means you have missed out on the chapters in genetics and in IEM where they talk about WES. Don't worry, we'll do a brief review here. Whole exome sequencing is a molecular technique to identify those genes, those diseases which have multiple genetic involvement, multiple gene involvement. Let us first understand about methylmalonic acidemia. It's a tough topic. So I'll not go into the details of the disease. I'll go into the basics, the concepts behind it. So what is methylmalonic acidemia? They belong to a group of organic acidemias which are inborn errors of metabolism. So they are a group of inborn error of metabolism characterized by impaired conversion of methylmalonyl coenzyme A into succinyl coenzyme A, and so their methylmalonic acid levels are elevated in the body. MMAs can be isolated or they can be combined with other acidemia. So basically MMAs are of two types. Isolated ones are also called as small I MMA. And combined MMAs are also sometimes written. This nomenclature is not there in Nelson, but other review articles. I'm taking the help of many textbooks to give you a summarized view. So CMMA. This question which was asked in NEET SS 22 was, you will not directly find given in Nelson, so we have to push the boundaries a bit. So MMAs can be isolated or combined with other acidemias. And there is a whole multiverse of genetic involvement which can be responsible for MMA. So isolated MMA can have multiple genes. You have MMUT gene, we have MMAA gene, MMAB gene, MMADHC gene, and then there are some other rare genes also. These are the relatively common genes. Among them, you can get a one-liner. Which is the most common gene involved in methylmalonic acidemia? It is MMUT gene. It codes for methylmalonyl coenzyme A mutase. So this is the enzyme which is deficient and responsible for majority of cases of MMA. Then there can also be combined MMA, and one combined MMA. There are rare forms of combined MMA also. Common form of combined MMA is where MMA coexists with homocystinuria, and they can have gene involvement of MMA-CHC, ABCD4, PRDX1 genes, etc. Now all these genes are present on different chromosomes. Do you think it is possible to individually analyze each gene, or to screen it using FISH technique or similar techniques? It is not possible. So this is where the role of the newer genetic techniques, the newer molecular diagnostic techniques comes into play. One useful way to make genetic diagnosis is by WES or whole exome sequencing. Can we do some other sequencing techniques? You can go for next generation sequencing, also called as NGS, that can also be tried, or you can go for WGS, whole genome sequencing. More on this we will talk in some time. So let us do a quick review of whole exome sequencing. What exactly are we doing? Exome. What is exome? Exome is a collection of genes which codes for protein. So basically it is a collection of exons. Introns and exons. Exons are the coding part. So it is a collection of exons. We are only doing sequencing of these genes. So WES is a genetic test that analyzes the exome, that is the portion of the DNA that codes for protein, that is exons. And while the exome makes up only 1 to 2% of the entire human genome, we have a lot of gibberish material which generally doesn't code for anything. But this exome contains roughly 85% of all known disease-causing mutation. And this makes it a cost-effective and efficient way to search for the genetic cause rather than sequencing the entire genome. If you sequence entire genome, you call it as WGS. But if you sequence only exome, it is an efficient and more cost-effective way to screen for genetic mutations. And in many organic acidemias like MMA, if initial metabolic workup like TMS or urine GCMS, they do not provide a clear diagnosis, WES can be a next step. So, Nelson 22nd edition also says, have a look here. I will highlight the word that you need to see. This is Nelson 22nd edition. It says, when multiple genes can cause a particular disorder, it is sometimes more efficient and cost effective to screen large number of disease causing genes using a panel. What are the options they said you can use? You can use next generation sequencing technology, also called as NGS. When such panels are not available or when the diagnosis is in question, the better test, which is more suited in case of doubtful diagnosis, is WES sequencing, whole exome sequencing, and it is also clinically available. Of course, India is a resource limited country, but it is now being increasingly made available. And whole genome sequencing is another clinical option, but as I just told you, these patients, there will be difficulty and it will be longer to do. It will take longer time, more money will also be taken, more time will also be taken. It will be a more intensive procedure. So remember, if you have to look for those genetic disorders where multiple genes are involved across various chromosomes and the diagnosis is in doubt, there are 3 molecular diagnostic techniques you can employ. You can go for next generation sequencing, also called as NGS. You can go for WES, whole exome sequencing, and you can go for WGS, that is whole genomic sequencing. This one is ideal, more like a gold standard, but kept reserved. These are the 2 ones which you actually need to look for. Among them, which is more accurate, the more accurate one, more clinically useful one is WES. Again, there are 2 schools of thought. One school of thought says actually NGS can also be, it is equally valid, and some people prefer doing NGS. But if you look at all the review articles, WES is the one that we go for. I hope you have got a fairly good idea of what Nelson and different textbooks are saying. What examiner will ask, we have no idea. But this topic, a brief discussion was mandatory because this is something that we have not discussed in the regular videos already. So keep that in the back of your mind. End of the day, it's a previous year question. Moving further, question number 3. Before I start with question number 3, clarification. Very simple, one-liner based previous year questions. I'm trying not to include, because if someone is asking cause of viral diarrhea in a child and the answer is rotavirus, it would be a shame that I am teaching that to you when you all are smart people and already done the MD Pediatrics. So I'm only choosing those particular topics and points which I feel are relevant and can have a repeat value. So question number 3. A child with developmental delay, seizures and cherry red spot on fundus examination is evaluated. And enzyme assay reveals deficiency of hexosaminidase A. Now we have 2 types of information, deficiency of hexosaminidase A and cherry red spot on the fundus. What is the likely diagnosis? If you have both the things along with CNS involvement, we are dealing with Tay-Sachs disease. And Tay-Sachs disease is a type of GM2 gangliosidosis. So there is accumulation of which metabolite in the body? It is GM2 ganglioside. That is the answer. About this question I have put here. The topics I have put here, I again repeat, these topics are also high yielding topics. So one way is you listen to the discussion of these videos and all. You have taken the test already, you see where you are standing, that is number 1. Number 2, all the additional points I'm telling you, you add them somewhere on and you revise them well before the exam so that some PYQ or important topic doesn't get missed. Number 3, these topics are also high yielding per se. So when you are doing revision, you can't revise everything. These topics should not be missed. All the topics I'm covering in all these test and evaluation program. So it's a 3-pronged approach we are taking. Now Tay-Sachs disease, it's an easy one. Diagnosis is an easy one. There is a very good chart I always use. I am very fond of this chart, lysosomal storage disease. Now this chart tells us that, look at enzyme number 1. Enzyme number 1 is hexosaminidase A. If there is deficiency of this enzyme, GM2 gangliosides cannot form GM3 gangliosides and that disease is called as Tay-Sachs disease. So what will accumulate? GM2 gangliosides will accumulate. Variation of Tay-Sachs disease is Sandoff disease. In Tay-Sachs disease, only hexosaminidase A is deficient. In Sandoff disease, hexosaminidase A and B both are deficient and that has a more severe systemic involvement, and so on those patients you will also have hepatosplenomegaly. Second, we have look at this enzyme number 2, that is alpha galactosidase A, and that enzyme deficiency leads to difficulty to convert ceramide trihexoside into glucocerebroside, and that disease is called as Fabry disease. The third one is your Gaucher disease, the typical one in which you have hepatosplenomegaly, you have CNS involvement, you have Erlenmeyer-Flass deformity. So bony involvement can also occur in some patients in some variants. The enzyme deficient is glucocerebrosidase, also called as beta glucosidase, and there is accumulation of glucocerebrosides. These glucocerebrosides are the ones which are responsible for producing the crumpled tissue paper appearance. You remember crumpled tissue paper appearance of cells in reticuloendothelial system that occurs due to glucocerebroside involvement. Then we have enzyme number 4, that is aryl sulfatase A, which is responsible for metachromatic leukodystrophy. So sulfatide molecules cannot be converted into galactocerebroside. Fifth one is your Krabbe's disease, which occurs due to galactocerebrosidase deficiency. So ceramides cannot be formed. And finally, we have Niemann-Pick disease, which is due to sphingomyelinase deficiency. Sphingomyelin accumulates and ceramides will not be formed in the patient. So this is a very important table. Last week, you can always review and it may just help you in the exam. Now, next question is also related to this topic only, and then we will summarize a few points. Let us have a look at question number 4. The answer to this is very clear, right? It's an easy one. Question number 4. A child presents with hepatosplenomegaly and cherry red spots in the eye. He also has developmental regression with normal startle response, likely enzyme deficiency. Now, I'm quite sure some of you have made the mistake of looking at cherry red spot and marking and neuroregression and marking hexosaminidase A, thinking it is Tay-Sachs disease. Cherry red spot is seen in Tay-Sachs, but it is not the only reason. And second thing, Tay-Sachs disease will not have hepatosplenomegaly. That is a feature of Sandoff disease. And startle response, this is an important consideration. So what exactly is the diagnosis? How do you reach a diagnosis in such question? Whenever you have a case scenario given to you, and then they have enzymes given, in your mind, first of all, try to see which enzyme deficiency is producing which disease. And then do you try to see whether that disease corresponds to the clinical feature given or not. Let me give you an example. There is a reason I have put this question. I just want to tell you the right way to approach such question. Don't directly jump to the enzyme. First of all, keep in your mind, what are the diseases getting produced from the deficiency of these enzymes. Glucocerebrosidase deficiency, I just told you, that produces Gaucher's disease. Sphingomyelinase deficiency produces Niemann-Pick disease, also called as NPD type A. Aryl sulfatase deficiency produces MLD, metachromatic leukodystrophy, and hexosaminidase deficiency produces Tay-Sachs disease. Right? Now you try to see where is it fitting. First of all, can it be Gaucher's disease? The answer is no, it cannot be Gaucher's disease. Why? Why it cannot be Gaucher's disease? Because there is no cherry red spot. No cherry red spot in Gaucher's disease. So this one is ruled out. Second, can it be MLD, metachromatic leukodystrophy? No, it cannot be MLD. Why? Because these patients have no hepatosplenomegaly. No hepatosplenomegaly occurs in MLD. That is also ruled out. Third, it is not hexosaminidase A deficiency. It is not Tay-Sachs disease. Why? Because Tay-Sachs disease, there is no hepatosplenomegaly. In Tay-Sachs disease, I'm just writing the short form, Tay-Sachs disease. Plus, there is exaggerated startle response. What is exaggerated startle response seen in Tay-Sachs disease? It is also called as hyperacusis. Hyperacusis or exaggerated startle response, even with slight normal sound or flash of light, but generally sound is seen in these patients and the child will start crying. So Tay-Sachs disease is not likely. What are we left with? Sphingomyelinase deficiency, that is NPD type A, and that is the answer. Will NPD type A have normal startle response? Yes. Would it have a cherry red spot? In some patients, yes. Hepatosplenomegaly? Yes. Would it have developmental regression? Yes. So by exclusion, your answer to this question is C, sphingomyelinase deficiency. Remember, cherry red spot, originally described for Tay-Sachs disease, can also occur in Sandoff disease. It can occur in 50% patients of GM1 gangliosidosis. It can also occur in sialidosis. It can also occur in NPD type A. Right? Let us have a look at important hot topic. Recent exams, particularly INI SS exam. in the general pediatrics part, they are asking questions on GM1 gangliosidosis versus GM2 gangliosidosis. This is useful even for your fellowship exams. So I'll not go into the technical details. They are there in Nelson, and I'm quite sure you know them well. So first of all, if the question, look at the question, case scenario. Case scenario based approach is important. Buzzwords, keywords are important. If the examiner says coarse facial features, hepatosplenomegaly, neurodegeneration, cherry red spot in 50%, corneal clouding and angiokeratoma, you will think of GM1, gangliosidosis in the patient. But if the examiner says no coarse facial feature, no corneal clouding, cherry red spot with exaggerated startle response, large head macrocephaly along with neurodegeneration, developmental delay, seizures, etc., your answer will be GM2 gangliosidosis. Which one? Tay-Sachs disease is being talked about. And if the examiner says cherry red spot with exaggerated startle, macrocephaly, neurodegeneration plus hepatosplenomegaly also comes in, this is GM2 gangliosidosis, which is due to Sandhoff disease. It is due to Sandhoff disease. So these are the three scenarios. They are very important. Look at the keywords. Don't miss them if you get a case in the exam. And every word is important. You cannot remember everything, but important distinguishing points you have to remember. And another extra edge, all of you who read from Nelson, and I'm expecting that apart from soft copy, you also have access to the good old traditional hard copy cover of Nelson. There are two tables given in the chapters of lipidosis. One, the very big tables. Using a color pen, just mark in that table where do you find cherry red spot, where do you find coarse facies, where do you find optic atrophy, and not all diseases, only the major ones. There are two such tables you will find. Those tables, again, very important. Now, I'm simplifying things for you, and it is there in Nelson, so I'm not showing the table anyways to you. Nelson is there with you. But if you have time, if you don't have time, it's great. It's not great. It's okay. But if you don't have time allows, just go through those tables and at least something out of that table will definitely be asked. I just want to, discuss these test and discussion parts in a way that we are simplifying and we are doing it. I cannot see you. It's a recorded thing which is going on. But I am taking an approach where I'm trying to simplify things for you. I'm not just going on talking about it. Some easy things will also come where I will just tell the diagnosis and ask you to mug it up. But these are the key points. I'm taking a lot of time only for you to understand the keywords. Keywords clinch the diagnosis. Next, question number 5. It's an easy one. A neonate on exclusive breastfeeding presented to emergency with recurrent vomiting, hypoglycemia, jaundice and hepatomegaly. So there is a liver related crisis with hypoglycemia. Urine was positive for non-glucose reducing substances on Benedict's test. And if you look at the options, they are talking about varieties of galactose. So basically the diagnosis is galactosemia. And which is the galactosemia which presents with in the first week of life, in newborn period, with jaundice, hepatomegaly, hypoglycemia. It is the classic galactosemia. This is the variety which is common, which is severe, and it is having GALT deficiency, also called as GALPUT deficiency. And so, which is the metabolite responsible for hepatotoxicity? It is galactose 1-phosphate, which is responsible for hepatotoxicity. Now, you need to understand there are two important metabolites which get accumulated. Galactose is not forming glucose. Galactose 1-phosphate is directly hepatotoxic, whereas galactitol is the one which is responsible for producing cataract. There is oil drop cataract which is produced. Galactitol is the alcohol derivative which absorbs and retains water and causes swelling in the lens region. So oil drop cataract, galactitol. But if they say hepatotoxicity, galactose 1-phosphate will be your answer. So this is the table. We have discussed it already in detailed video as well as in rapid revision. You can see that galactosemia theoretically can occur due to 3 enzyme deficiencies: galactokinase deficiency, epimerase deficiency, galactose 1-phosphate, uridyl transferase. Which is the one which is most common as well as most severe? This is the one which is most common. There is accumulation because the block occurs. So galactose 1-phosphate accumulates. This galactose 1-phosphate is hepatotoxic, and the derivative of galactose and galactose 1-phosphate called as galactitol, that is responsible for cataract in the patient. So remember some 2 or 3 points about galactosemia. galactitol is responsible for producing oil drop cataract. It can also rarely sometimes lead to CNS damage, CNS involvement. However, galactose 1-phosphate is the one which is responsible for hepatotoxicity and some degree of renal toxicity also. And the risk of E. coli sepsis is significantly raised in galactosemia. Treatment, of course, is avoiding galactose as much as possible. Now, question number 6, it's a easy question actually, progeria topic you can review after this discussion is over. All of the following are true regarding progeria except, now let us go one by one. Insulin resistance is common beyond 8 to 10 years of age. Yes, it is true. It is a true statement. Stroke is the leading cause of death in these patients. False. The most common cause of death is cardiac involvement. Myocardial infarction due to accelerated atherosclerosis is responsible for roughly 80% of all deaths. Stroke can occur, but stroke per se is not the most common cause of death. Fiber optic intubation is the preferred mode. Yes, the conventional intubation where indicated, it is not easy, and so you have to go for fiber optic intubation in such patients. And fourthly, intelligence, brain is not affected as a part of aging. Reason being, progerin is the abnormal protein which is expressed, and in brain there is less expression, down regulation of progerin protein, so intelligence remains normal. So option number C is true, option number D is true. If you look at the option, they are asking except, all are true except, so B is your correct answer. Question number 7. Identify the incorrect match of type of mucopolysaccharidosis and the corresponding accumulated GAGs, glucosaminoglycans. So it is based upon a table. We will discuss the table, look at the options one by one. Type 1H, Hurler disease. Can it have accumulation of dermatan sulfate and heparan sulfate? It is true. Type 1S, dermatan sulfate, heparan sulfate, this is same, basically Shy's disease. And type 3 is heparan sulfate, yes. Type 4, Morquio syndrome. No, dermatan sulfate plus chondroitin sulfate is not seen. Type 4 is associated with keratin sulfate deposition. They are asking to identify the incorrect match, and so the answer to this question is D. So what do we need to know? GAGs, mucopolysaccharidosis, important topic. Go through name, number, enzyme deficiency, what is accumulated. And details you can do only 3 or 4 of them. Hurler versus Hunter, how do you distinguish which is having corneal clouding, which is not having corneal clouding? By this time you already know the difference. You know, corneal clouding is there in Hurler but not there in Hunter. Hunter does not have corneal clouding, so he can focus on the target. Those kind of mnemonics we always make. My suggestion, please go through Morquio syndrome also. It is a cause of short trunk dwarfism and has been asked once in the previous older papers of NEET SS exam. So question number 7, the answer is D. This is the table that I am talking about. So question, we have mucopolysaccharidosis numbers on one side, we have the names on the other side, we have which is the increased GAG. You can easily see that in Morquio A as well as Morquio B, the two subtypes of Morquio, it is always keratin sulfate which is accumulated and not heparan sulfate and dermatan sulfate. And enzyme deficiency in Morquio syndrome is galactosamine 6 sulfatase and beta galactosidase. Only one is X-linked recessive, that is Hunter, all other are autosomal recessive. Do you need to remember the gene location? I don't think so, not needed, except for first or second you can remember. And then this remaining part, this entire remaining part, these and these, just try to remember it. This table is not there in Nelson, it is there in the other books, one review article I have taken it from. So please remember this table. It's a very beautiful table and close to the, eventually you will have to mug it up. Write it down, post it somewhere you can see regularly, and maybe use it as your wallpaper for a few days till it becomes a part of your muscle memory. Let's go further. Question number 8. GDF testing is a useful screening test for which among the following? Growth and differentiation factor number 15. It is a useful screening test for mitochondrial diseases. It's a direct one-liner I have taken from the older papers, and this is also discussed in the detailed videos that we have talked about. So it's an old NEET SS. It is an old NEET SS 2019 MCQ. Now you might be thinking, sir, 2019 question? 2019 question is also important. End of the day, it's the same thing. The more things change, the more they remain the same. Some topics are always important. So GDF15 testing. See, mitochondrial disease per se, it's not a very specific test, but it has a fairly good sensitivity. And for those especially where respiratory involvement or energy generation is getting affected significantly, GDF15 testing can be useful. Generally, we use a combination of lactate and GDF15 testing, and Nelson also talks about it. So what are the things you should know? GDF15 stands for growth and differentiation factor number 15. It is also known as MIC1. What is MIC1? Macrophage inhibitory cytokine 1. It is a member of the TGF beta superfamily. And what is it useful for? It is useful for screening of mitochondrial diseases. What is the limitation? What is the limitation? The limitation in the patient is GDF15 can also be elevated. It can also be elevated in obesity, old age, metabolic syndrome, MS, as well as certain malignancies or cancers. So it will be elevated there as well. The best diagnostic test for mitochondrial disease is WES or WGS, either of the two. We have already done. What is WES? Whole exome sequencing, whole genome sequencing. And another extra thing, if they ask you gold standard investigation is also given in Nelson as well as in the popular review article, which many of you might be reading, you might have read in your preparation days for university exam. There is a test known as electron transport chain. You know, mitochondria has electron transport chain. So electron transport chain enzyme assay is the gold standard investigation, and it can be done in a frozen tissue sample. In a frozen tissue sample. You don't need blood for that. In a frozen tissue sample, you can perform it. So this is regarding mitochondrial disease investigations. This is what I wanted to emphasize. Let's go to question number 9. A 3-year-old child with developmental disability, seizures and cardiomyopathy was suspected to have congenital disorder of glycosylation, CDG. It's a topic most of us do not read, but occasional question you will find. The screening test of them is important. So what testing made you suspect this group of disorder? In other words, if there is CNS involvement, cardiomyopathy, maybe plus minus failure to thrive, there can be a whole lot of causes. They are saying one test was positive which made you think of CDG. What is that test? So what is the screening test for CDG? Abnormal pattern of serum transferrin isoelectric focusing. We call it as TIF. So serum TIF testing, if it is abnormal, that goes in favor of congenital disorder of glycosylation. It's a tough topic. Let's understand briefly, very briefly, what do we need to know. So congenital disorders of glycosylation, they are a group of multi-system disorders predominantly characterized by defect in N-glycosylation of proteins and lipids. N-glycosylation of proteins and lipids are important for signal transduction, they are important for important structural formation, and they also play a role in various metabolic processes. So this is a inborn error of metabolism where N-glycosylation gets affected due to congenital enzyme deficiency. The most common type is PMM2-CDG, and it occurs due to deficiency of the enzyme phosphomonomutase 2. So that is why the name comes PMM2 type of CDG. Screening test in these patients, I just told you serum TIEF that can be used, and in these patients the serum TIEF levels, they become abnormal. But the diagnostic test is CDG gene panel analysis, or you can go for whole exome sequencing. And treatment in the patient is dietary therapy, and acetazolamide can be useful in PMM2 type of CDG. It is not useful in other cases, but it can be tried in the common variety. Dietary therapy is the mainstay of management. It's a big topic by itself. It has never been asked per se, so we are not going into the details. If it does get asked, again, we cannot stop the examiner for putting. To be on the safe side, a few words about CDG you can always go through. There is a big chapter given in Nelson. My advice is just read the first page, and apart from that, the PMM2 CDG and the second most common after that, just go through these two. That's all you need to do, and read about the therapy part. Because this topic has never been asked directly in the exam, so we are not going into the details. Rare things, because Pediatric science is vast. We cannot do everything. Question number 10. Nitisinone is indicated in the management of which among the following tyrosine abnormalities? Nitisinone. Nitisinone is a 4-HPPD inhibitor which is considered the drug of choice in patients of tyrosinemia type 1. How does nitisinone act and where else it is useful? It is also useful in alkaptonuria. How? Let us have a look at this funda. Now this is the phenylalanine metabolism, one of my favorite cycles again. I always try to make students read about it. In my detailed videos, I have gone through this same cycle. Now, what is tyrosinemia type 1? It occurs due to deficiency. Look at this. Deficiency of fumarate acetoacetate hydrolase. And that deficiency leads to development of tyrosinemia type 1. Because fumarate acetoacetate now cannot be converted, it cannot be broken down into fumarate plus acetoacetate. Fumarate acetoacetate level will be increased. This will be diverted towards succinyl acetoacetate and succinyl acetone. Succinyl acetone and fumarate acetoacetate, both of them are toxic to the tissues. And particularly hepato and neurotoxicity can be produced by this particular culprit, succinyl acetone. So if you want that succinyl acetone should not form, which drug will be given? Something which blocks before fumarate acetoacetate forms and before mallyl acetoacetate also forms, because that can also form succinyl acetone, and that drug is nitisinone. Nitisinone is a 4-HPPD inhibitor. It inhibits the formation of homogentisic acid, and so succinyl acetone formation reduces, leading to symptomatic recovery and toxicity is reduced. Now, what is alkaptonuria? Alkaptonuria is a inborn error of metabolism. You remember black urine, black discoloration of the tissues. That again is due to homogentisic acid oxidase deficiency, also called as homogentisate 1,2-dioxygenase deficiency. And the pigment getting formed is from homogentisic acid. So if you give nitisinone, again the pigment will not form. So you can simply remember that nitisinone is the drug of choice in two conditions. What are the two conditions? It is drug of choice in tyrosinemia type 1 and it is drug of choice in alkaptonuria. However, in the other forms of tyrosinemia, this has no role in the management, and this chart is telling you very clearly. So, answer to this question is C, that is tyrosinemia type 1. Let us move to question number 11. 10-year-old child has been diagnosed with SLE using EULAR criteria. He has a high ANA titer, low double-stranded DNA titer, skin rash, oral ulcer but no lupus nephritis. Which of the following shall be the preferred therapy for maintenance after remission? Now, there are a few things you need to understand. This is a patient with SLE, but there is low double-stranded DNA titer. Double-stranded DNA titers are indicative of activity in the disease. So, the disease is getting under control and there is no lupus nephritis. So, it is like a non-life-threatening SLE. And they are asking for maintenance therapy and after remission has been attained. Now, you need to understand that steroids will never be useful for maintenance therapy. Low dose steroids are given in dire circumstances, but vast majority of patients, particularly after remission has been attained, we try to taper off the steroids, and hydroxychloroquine alone is the therapy of choice for maintenance in such patients. Right? So, it's an easy question, but there are a few principles of SLE that we need to know. Let us keep all the technicalities aside. Let us understand in a simplified manner. If a question is asked to you and they give you a case scenario and they ask you the treatment principles, how you are going to approach. So, treatment principle I am talking about. This is in addition to whatever we have discussed in SLE topic in rapid revision. So, treatment principle says, first of all, let us assume there is non-life threatening SLE. I am assuming that you all know that sun protection has to be done in all forms of SLE. Okay, it will reduce the flares. So, non-life threatening form of SLE, for example, skin involvement. What is the agent of choice? Initially, you will be starting with initial drug of choice in such patients will be oral hydroxychloroquine. Hydroxychloroquine, I am writing in short as HCQ, oral hydroxychloroquine. And if there is severe manifestation, you can give a short course of steroids. You can use a short course of steroids like prednisolone, and then you can taper it and continue with hydroxychloroquine. And for maintenance, you will always be using hydroxychloroquine alone. You will not be giving anything else in the patient. If the examiner is asking you about life-threatening SLE, for example, patient is having lupus nephritis. Now in these patients, first of all, you need to attain remission, and for remission, hydroxychloroquine alone is not sufficient. So you will be, for remission, you will be using high dose corticosteroids. You can use high dose prednisolone, or you can combine it, or you can alternatively use methylprednisolone also. So steroids will be combined with cyclophosphamide. If the patient is not tolerating cyclophosphamide, or is there any contraindication to that, the alternative therapy you can use is steroids along with mycophenolate mofetil. And generally this combination needs to be given for up to 3 to 6 months. If they ask you to pick one, the better answer according to CARA guidelines is 6 months. But some of the regimes, they tend to follow for 3 to 6 months. And once the remission has been attained, for the purpose of maintenance, you will be putting the patient on hydroxychloroquine, and steroids will be gradually tapered. If on tapering the steroid, the patient is having any type of relapse or incomplete maintenance of control of symptoms, you can consider combining or adding azathioprine in such patients. Azathioprine you can consider, you can even very low dose mycophenolate can also be tried. But if you see overall, for maintenance purpose, it is hydroxychloroquine which is our therapy of choice. And because this question is asking about hydroxychloroquine, it is asking about the maintenance after remission has been attained, the answer will be hydroxychloroquine alone. So this particular thing will be useful if you get a case scenario. And Nelson 22nd edition also says that hydroxychloroquine is recommended for all individuals with SLE when tolerated. It not only controls symptoms like rash and mild arthritis, it prevents SLE flares, improves lipid profiles, and also has a beneficial impact on mortality and renal outcome. Also a one-liner question, INI Super Specialty 2023, one-liner question, what is the most common cause of death in pediatric SLE as well as overall SLE? Two variations of this. One option said sir overall पूछा था, one said pediatric and adult, ऐसा लिखा था. So whatever it was written, we don't know what it was written. Most common cause of death in SLE is always cardiac involvement. So MI, myocardial infarction, that is cardiac cause, is the cause of death. Apart from that, you have infections, thrombosis, and with the advancement of MMF, cyclophosphamide based regimes coming in, lupus nephritis is not a common cause of death anymore. Although it is a severe disease, but it is not a major cause of death among the top 3 causes right now. So these learning points you can add. Moving to question number 12. It's an easy one. Child presented with fever, fatigue, myalgia. He has proximal muscle weakness, and you can see in the photograph. Can you see this rash which is present? This purple colored rash on the upper eyelid. This is again indicative of heliotropic rash of juvenile dermatomyositis, and the patient is having anti-TIF1G antibodies positive, CK levels are elevated. So what is the diagnosis? Patient has juvenile dermatomyositis, JDM. Now, which other antibody will be present in the patient? You have to see one thing that you might be missing. This is what you call as mechanic hands, and whenever mechanic hands are there in JDM patient, you will have anti-Jo1 antibody to be present in the patient. And so your answer to this question is B, anti-Jo1 antibody. Mechanic hands, strong association. What about topoisomerase 70 and RNA polymerase 3? They are seen in SSC, that is scleroderma. So scleroderma patients will have it, the diffuse form. And anticardiolipin antibody can be seen in SLE, it can be seen in antiphospholipid antibody syndrome, etc. So the answer to this question is B. Now, let us do a quick review. Juvenile dermatomyositis, you can get a photograph. JDM is having dermatological involvement plus myositis, that is inflammation of the muscle, particularly proximal muscle. So you have purple colored rash known as heliotropic rash, you have Gottron papules present on the knuckles, you have V sign photosensitive rash on the anterior aspect and Scholl sign at the posterior aspect, and you have nail bed telangiectasias. Along with that, these patients will have proximal muscle weakness. Proximal muscle weakness will be in the form of upper limb and lower limb involvement. Upper limb involvement, they will have difficulty to comb the hair, difficulty in raising hand above the head, and lower limb abnormality will be in the form of difficulty to climb up and down the stairs. And how do you make the diagnosis? This is the diagnostic criteria. Classic rash is there, heliotropic rash or Gauthron papules. They have to be there. That is essential criteria, plus any three of the following. There should be proximal symmetric muscle weakness, muscle enzyme elevation, at least one or more of these. EMG changes should be there, and muscle biopsy. Muscle biopsy is gold standard. It is only done in selected cases. So this is how you make the diagnosis. Treatment of choice obviously will be steroids. Now, question number 13. Now, this is an important question, and this question is similar to, I'm writing here, it is similar to INI SS MCQ in 2022 mid-year. It is very similar to that. So, question number 13, a child with Kawasaki disease was treated with IVIG, there was a reduction, there was improvement in the patient, there was a response. However, echocardiography shows coronary artery aneurysm of size 10 mm on right coronary artery. Which of the following should be planned in this child? It's a proper topic. It's a mini discussion also we can do. Let us talk about the common complication of Kawasaki disease which causes mortality and long-term morbidity, coronary artery aneurysms. What is aneurysm? It is a dilatation or outpouching of a vessel or hollow viscus. So, coronary artery aneurysms are the most common cause of death, and the reason is acute coronary thrombosis. There is MI which occurs due to thrombosis. Second common cause of death in CAA is the rupture of a giant aneurysm. They appear between 2 to 6 weeks of disease onset, so they are not present in the first week of Kawasaki disease. They are seen in 15 to 25% of untreated patients and less than 5% of IVIG treated patients. Now, the classification of these aneurysms is done based upon echocardiography. There are three varieties which are defined: small, medium, giant. The American Heart Association uses percentiles, standard deviations, whereas the Japanese one uses absolute dimensions. So, small coronary artery aneurysm is the one which is between 0 to 4 mm in size. Medium is the one which is said to be between 4.1 to 8 mm, and giant aneurysm is the one which is having an absolute dimension size more than 8 mm. If the definition of giant aneurysm according to AHA, it is also defined as equal to or more than 10 Z-score. So, Z-score value equal to or more than 10 is also considered to be giant aneurysm, right? So, this is the dimension you need to know. Now, how do you manage these aneurysms? So, anticoagulation therapy will be indicated. If aneurysms disappear, you can taper and stop the aspirin, and some of the patients about 6 to 8 weeks after the onset of disease, you can actually stop them. But if on follow-up, you find that echocardiography is showing persistent aneurysm, how you are going to go? If it is a small aneurysm, you will continue low-dose aspirin 3 to 5 mg per kg per day. Till how much time? Till aneurysms disappear. If it is a medium aneurysm, you will use aspirin in the same dose with or without clopidogrel. And third, if there is giant aneurysm, aspirin should be used along with anticoagulation therapy. You can use either warfarin or low molecular weight heparin or direct inhibitors, oral inhibitor like apixaban. And acute coronary thrombosis, if it happens, prompt fibrinolysis with tissue plasminogen activator TPI, fibrinolysis of the thrombus should be done. This is the management, and there is a table given in Nelson on this as well, very important, and it's just a topic waiting to be asked in the exam or in NEET SS exam. INI SS, similar question, not the same but similar question has already been asked once. Now, look at the question again. Now, what is the question saying? Echocardiography revealed a coronary artery aneurysm of size 10 mm. So, 10 mm size means it is a giant aneurysm, and giant aneurysm you will give low dose aspirin along with warfarin in the patient. Now, question number 14. This is similar to NEET SS actual to 2024 PYQ. A 3-year-old child presented with high-grade fever, strawberry tongue and rash. You are suspecting incomplete Kawasaki disease. Which of the following tests shall not be required in the evaluation? So, basically they are asking you about the table given, the flowchart given in Nelson 22nd edition, evaluation of incomplete Kawasaki disease. Let's do a quick review. If there is incomplete Kawasaki disease, what is incomplete Kawasaki disease? Patient is having fever along with 2 or 3 criteria. There is not all the 4 criteria getting fulfilled. So, children with fever 5 days, or more and 2 or 3 compatible criteria, or infants with fever for equal to or more than 7 days without other explanation, you will suspect Kawasaki. So assess the laboratory test. If there is CRP less than 3 and ESR less than 40, they are not elevated, you will do serial evaluation if the fever persists, and echocardiogram, this is important, echocardiogram should be done if typical peeling, the periungual desquamation develops in the patient. I am putting a star here. So if there is low acute phase reactant, you will do echocardiography only if peeling of skin occurs. That is the first learning point. Second, if the CRP and ESR are already elevated, cutoff you can remember, CRP more than 3, ESR more than 40, then you have to look for laboratory findings. Echocardiography is mandatory, we generally do. Any echocardiographic abnormality like aneurysms or myocarditis or laboratory findings. You will look for anemia, so you will do a CBC count. You will look for platelet count, elevated beyond 7th day of fever. Thrombocytosis is a feature, not thrombocytopenia. Low serum albumin, elevated ALT level, WBC count, and urine showing pyuria that is equal to or more than 10 WBCs per high power field. With this in mind, and if any of them is fulfilled, you treat the patient. Now, question number 14, this is incomplete Kawasaki, and albumin will be done, less than 3 will be indicating going in favor of Kawasaki. Complete blood count, you have to look for anemia and platelet count. Urine for WBC, yes, you look for pyuria. What about serum ferritin? Serum ferritin is not required for evaluation of incomplete Kawasaki disease. By exclusion, the answer is B, serum ferritin. Question number 15. Easy one-liner, child with palpable petechiae on lower limb, joint pain, abdominal pain. Patient is having IgA vasculitis, that is Henoch-Schönlein purpura. Which of the following is an indication of giving steroid? Most patients of Henoch-Schönlein purpura improve without therapy in 4 weeks. Steroids like prednisolone are given for 1 to 2 weeks if there is severe GIT involvement. For example, there is GIT bleeding. If there is bleeding per rectum, then you will be giving it. If HSP nephritis happens and it is non-responsive, there also you can use, but HSP nephritis prevention, it is not indicated, right? So, and C and D, they are just added to fill up the options. So, remember when to give steroid in HSP? If there is severe GIT involvement. That is all you need to remember. Question number 16. A child with systemic onset GIA has been diagnosed with macrophage activation syndrome. All of the following are indicative of MAS except. Now, this is an important topic. Macrophage activation syndrome is a common cause of morbidity mortality in systemic GIA patients who do not respond to the usual therapies. Macrophage activation syndrome is a type of HLH, that is hemophagocytic lymphohistiocytosis syndrome. Now, about these parameters and the values which are given, they are scattered throughout Nelson. But I want you to understand that apart from the diagnostic criteria of MAS, which you will be reading and which is there in the detailed video, some additional points you need to know. Macrophage activation syndrome indicates interferon gamma hyperactivation. I repeat, interferon gamma hyperactivation. And CXCL9 and interleukin 18 are both related to it. Let us see what Nelson is saying. Have a look at this screenshot. Nelson says that in MAS, there will be abundance of interferon gamma producing CD8 plus T cells in the inflammatory lesion. And CXCL9, a biomarker of interferon gamma activity, is elevated during an MAS episode. This is the important point. Also see that translational studies have shown that elevated serum interleukin 18 is a risk factor for development of systemic GIA as well as MAS. And a common link to the interferon gamma centric model is that interleukin 18 is noted for its ability to stimulate interferon gamma production by the T cells. You understand? So that is why, and interleukin 18 blockade has been shown to resolve the disease and also resolve the underlying MAS. That is why interleukin 18 elevated, that is a true statement. It is elevated in MAS. Raise CXCL9 is elevated, it is true. Interleukin 18, gamma interferon, CXCL9, they are all elevated. What about the soluble CD163 positivity? We are left with option number C and option number D. Answer has to be among these two. Let's go further. Nelson further says that diagnosis of MAS is supported by elevated levels of two markers in the blood, soluble interleukin 2 R alpha and soluble CD163 in the serum. So is CD163 positivity seen? Yes, it is seen. So what is the correct answer? All of the following are indicative mass except glycosylated ferritin more than 20% is not seen. Is ferritin elevated? Obviously yes. But they are not talking about absolute ferritin, they are talking about glycosylated ferritin. There are two types of ferritin, non-glycosylated and glycosylated. Let us see what Nelson has to say on this. So Nelson says that the most striking laboratory change in mass is the elevation of serum ferritin. This is something we already know. Okay. Now they are saying serum ferritin is usually 60 to 80% glycosylated, whereas intracellular ferritin is not glycosylated. In hemophagocytic syndrome, including MAS, the percentage of glycosylated ferritin in the serum is low, typically below 20%. And assessment of glycosylated ferritin may also be a useful tool for MAS diagnosis. So, what are the learning points in macrophage activation syndrome? The answer to this question is D. Remember, in MAS patient, macrophage activation syndrome patients, interleukin 18 will be increased, gamma interferon or interferon gamma levels will be increased, CXCL9, which is a marker of gamma interferon activity, that will be increased, CD163 will be increased, it will be positive, and patient will have glycosylated ferritin level, it will be less than 20%. But total serum ferritin will be significantly increased. So non-glycosylated one will be predominantly increased. So this is macrophage activation syndrome, biomarkers that you need to remember. Question number 17. Again, it is similar to past INI SS question 2023. So as I promised you, we are doing some previous year questions also alongside this discussion. So which of the following is favored agent for therapy in systemic GIA, especially in severe systemic symptoms? Now, in systemic GIA, non-steroidal anti-inflammatory drugs alone are not sufficient, and TNF-alpha inhibition is not very effective. It is not effective. So, in systemic GIA, it is interleukin 1 therapy and interleukin 6 therapies which are effective. So, anti-interleukin 1 and anti-interleukin 6 therapies are more effective. The example of anti-interleukin 1, you can use anakinra or you can use canakinumab, and canakinumab is anti-interleukin 1 beta. Anti-interleukin 6, typical example, it is tocilizumab. So, tocilizumab and canakinumab along with anakinra are the preferred biological agents that you will be using. Also remember that tocilizumab is anti-interleukin 6 R receptor. This is something I have discussed in the previous video also. So, what is the answer to this question? A. Canakinumab. Question number 18. Activation of JAK-STAT pathway with increased type 1 interferon. Increased type 1 interferon bind to interferon receptors. They activate JAK-STAT pathway. It leads to abnormal interferon related gene activation, and that in turn leads to interferonopathies. These disorders are called as interferonopathies, also called as type 1 interferonopathy, and the typical example for that is Aicardi-Couturé syndrome. Interferonopathy chapter and tragopathies chapter are there in the Nelson updates segment. Whether you are targeting NEET SS or INI SS, please go through these two chapters properly with a quick reading of Nelson. Very important. The whole purpose of me putting this question was something out of this is likely to be asked in the exam. Question number 19. This is NEET SS 2023 PYQ. A pregnant lady has anti-Rho, anti-La positivity. We know that if there is anti-Rho, anti-La positivity in pregnancy, they can cross from the mother, they can cross the placenta, reach the baby, and they have a tendency to damage the conduction system, particularly AV node, and they can cause congenital heart block. Which drugs can be given to the lady to prevent these manifestations from happening? Let us have a look at the brief review, quick review. Anti-Rho, anti-La positivity in pregnancy, very frequently asked. It's also an explanation of a previous year question. So, anti-Rho, anti-La positivity in pregnancy can cause complete heart block, and what is the reason for that? They cause AV node damage. AV node damage is the reason. So, what is the prevention strategies you can use for Nelson 22nd edition? First of all, hydroxychloroquine. Best evidence in Nielsen is for hydroxychloroquine. Or you can go for dexamethasone or betamethasone alone. You can go for dexamethasone combined with terbutaline, or you can go for IVIG administration. These are the 4 strategies which can be utilized in the pregnancy. And not all, one of these 4 can be applied. And going back to the question, and some books say if nothing else is working, risk is very high, plasmapheresis can be done. Now, question number 19. All of the following are indicated except, so hydroxychloroquine, dexa, terbutaline with steroids given. What is the answer? Leflunomide. Leflunomide has no role in the management of anti-Rho positivity in preventing cardiac damage in the fetus. And leflunomide anyways will not be given in pregnancy. Question number 20. A child presented with wrist arthritis, involvement of first metacarpophalangeal joint and nail changes as described. These nail changes are called as nail pitting or onycholysis. These are seen in patients with psoriasis. You need to understand, nothing else is there. Occasional nail pitting can occur in normal individuals also. But as a part of description, we are going in favor of psoriasis, and because arthritis is there, so psoriatic arthritis is the likely diagnosis. Now, how do you make the diagnosis? There is a classification criteria for psoriatic arthritis. It says that any one of the following, if it is present, we say psoriatic arthritis. Number 1, any patient with arthritis with psoriasis, we say psoriatic arthritis. Generally, it is oligoarthritis which is seen, and it is asymmetric arthritis which is seen, right? So, oligoasymmetric arthritis with psoriasis, psoriatic arthritis. Or if arthritis is present with 2 or more of the following. First feature, dactylitis, also called a sausage digit. Second, nail pitting or onycholysis. And third, psoriasis in a first degree relative. Psoriasis is not a good condition to have. It is not just a skin condition. It can have joint manifestation, which we call as psoriatic arthritis. Psoriasis itself is a chronic inflammatory condition. People with psoriasis are prone to develop metabolic syndrome as well as increased risk of MI, and not just MI, they can have stroke risk as well. But here in children, psoriatic arthritis can occasionally be seen. Question number 21. FOXP3 gene mutation is associated with which of the following? This is something I have discussed in regular videos, in the updates also. So, FOXP3 gene mutation directly associated with IPEX syndrome. IPEX syndrome literally stands for immune dysregulation, polyendocrinopathy, enterocyte involvement, and X-linked inheritance. This is IPEX syndrome, and they are associated with FOXP3 gene mutation. It is a type of tragopathies. So, I told you interferonopathy important topic, Nelson update, tragopathy important topic, Nelson update. So, what does Nelson say? IPEX syndrome is having immune dysregulation, polyendocrinopathy, enteropathy, X-linked syndrome. There is involvement of FOXP3 gene, and there is abnormalities in the function and development of CD4 plus, CD25 plus regulatory T cells. The absence of these Treg cells predisposed to abnormal activation of the effector T cells, which causes inflammation. So, answer to this question is A, IPEX syndrome. Question number 22. A child presented with complaints of recurrent swelling of limbs, face and airway requiring medical care. There is also episodic abdominal pain and positive family history. Family history, angioedema-like episodes, and episodic in nature, and no specific trigger mentioned. Most common cause, the patient is likely suffering from diagnosis of hereditary angioedema. Remember that hereditary angioedema is a autosomal dominant condition, and this is a previous year question of NEET super specialty. It occurs due to deficiency of C1-INH inhibitor. So, C1-INH deficiency is the reason, and recurrent episodes can occur in the patient. So, the answer to this question is C. Again, a topic we have discussed in details in the regular videos. Question number 23. A child with recurrent infection is having, we are into the world of immunology, generalized hypopigmentation, photosensitivity, ataxia, and prolonged bleeding time. What shall be most useful in the management? So, recurrent infection means could be a primary immunodeficiency, number 1. Second, hypopigmentation, albinism. Third, photosensitivity. And fourth, ataxia. Fifth, platelet abnormality, mild bleeding diathesis, bleeding time. Everything fitting into a diagnosis of Shediac-Higashi syndrome. Whenever you have immune issues with hypopigmentation and with platelet abnormality, always think of Shediac-Higashi syndrome. What will be useful? Ascorbic acid supplementation will be useful in these patients. Daily oral TMP sulfamethoxazole in high doses is generally not indicated. Even prophylactic antibiotics are occasionally seldom used. But high dose ascorbic acid has been shown to improve the outcome. So, Shirdiak-Higashi syndrome, let's do a quick review in the patient. You can see this is a hyperpigmentation, albinism like child. Clues will be hypopigmentation, photosensitivity, ataxia, increased bleeding time. Additionally, peripheral neuropathy can occur, and in fact, long-standing cases, progressive peripheral neuropathy, both sensory and motor, is the leading cause of problems in these children. Recurrent infections, of course, can occur. It is autosomal recessive condition. Lys gene is present on long arm of chromosome 1. There is defective degranulation of neutrophils and neutropenia is found in such patients. NK cell function is also reduced. Most common organism in these patients is Staph aureus. There is high risk of developing HLH syndrome. It predisposes to hemophagocytic lymphohistiocytosis syndrome. Treatment is high dose ascorbic acid, and eventual therapy will be HSCT if possible. Hematopoietic stem cell transplant will be needed. But the role of prophylactic antibiotic is limited. We do use them off-label, but they have a limited role in these patients. Now, question number 24. BCG vaccine is contraindicated in all of the following except. Would BCG vaccine is a live attenuated vaccine. So, would it be avoided in chronic granulomatous disease? Yes, it is to be avoided. They can develop disseminated BCG. Severe combined immunodeficiency, SCID, B cell, T cell, both are deficient, you will avoid. Interferon gamma R defects, again you will avoid. Myeloperoxidase deficiency, no need for contraindication of BCG vaccine. Remember, myeloperoxidase deficiency is a very mild and generally asymptomatic PID. What is PID? Primary immunodeficiency. So, which is the mildest asymptomatic but fairly common PID? It is myeloperoxidase deficiency, also called as MPO deficiency. The only risk in myeloperoxidase deficiency is they can have disseminated candidiasis, especially if there is a diabetes mellitus patient is there. So, any candida infection in MPO deficiency should be promptly treated, but otherwise no contraindication for live vaccine and no need for giving any prophylactic antibiotics. They are not indicated in myeloperoxidase deficiency. Question number 25. Most common mode of inheritance in SCID. There are many types of SCIDs. The most common type of SCID, you can see the picture given in Nelson. It is gamma C deficiency. It is gamma C deficiency, and gamma C deficiency always follows X-linked recessive inheritance. The second common variety is adenosine deaminase deficiency. This is the one which is most common, 45.8%, and so answer to this question is X-linked recessive. Remember, in SCID patient, BCG, MMR, these live vaccines are generally contraindicated. Question number 26. 1-year-old child with a history of recurrent infection. The mother recalls umbilical cord separation at the age of 4 weeks, quite late umbilical cord separation. Recurrent infection, delayed fall of umbilical cord. I have already told you in my videos, leukocyte adhesion defect, which is a phagocyte problem, should be suspected. So, there was a skin infection also which required admission for this and that. Autoantibodies and response to vaccination are normal. There are no autoantibodies and response to vaccination is normal, means the B cell function is not affected. What is the likely diagnosis? Patient is having leukocyte adhesion deficiency. So, multiple types, those subtypes we have been discussed. Now, because it's a test and evaluation program, you have taken the test, we are doing evaluation, we are doing discussion, I am telling you PYQs, one-liners, something extra I also need to give you. Something you already know, but if you just do it close to the exam, it will help you in consolidating whatever you have read. There are some PIDs which are more frequently asked compared to other, and when an examiner makes a case scenario, he inserts 1 or 2 words which take you in the direction of that diagnosis. So, clues for super specialty MCQ. Delayed fall of umbilical cord going in favor of leukocyte adhesion defect. These are clues. I am not saying one word will give you the answer, but these are clues. If they say recurrent infection with thymic absence or aplasia, hypocalcemia, Dye-George syndrome, catch 22. Recurrent pneumocystis, Girovaci pneumonia, PCP pneumonia, cryptosporidium infection, think of hyper IgM syndrome. It can occur due to CD40 ligand, also called as CD154 deficiency and CD40 deficiency. Please put a small Q here. This is a INI super specialty last year question, 2024 first half. There was an indirect question asked on this. And remember that this CD40 ligand deficiency is X-linked recessive, whereas CD40 deficiency is autosomal recessive. So both of them can produce hyper IgM syndrome. Then recurrent staph infection, candida infection, raised IgE, you will think of hyper IgE syndrome, we call it as Job syndrome. Then we have atopic dermatitis, that is eczema, small size platelet with decreased number, and recurrent infections due to abnormal antibody profile. Wiskott-Aldrich syndrome will be thought of. X-linked recessive, WASP gene occurs only in boys. Fetal varicella, ataxia, leukemias, ataxia telangiectasia. Fetal varicella and ataxia are the clues. It is cerebellar ataxia which is seen. Then recurrent and severe Giardia infections goes in favor of selective IgA deficiency. Remember, selective IgA deficiency also associated with celiac disease. It is considered to be a part of the spectrum of celiac disease only. And granuloma formation is the hallmark, along with recurrent staph infection, recurrent catalase positive infections including by Serratia mascarinans infection. Likely diagnosis CGD, chronic granulomatous disease. So these are some very important clues you can add to your notes and do revision in the last week also. Then we have question number 27. Open vial policy is applicable to which among the following? Open vial policy is only applicable to inactivated vaccines. They are not applicable in live vaccines. So live vaccine, BCG, no. MR, no. Rotavac oral is no. Kolar strain of Japanese encephalitis vaccine is inactivated vaccine. The brand name of this vaccine is Genvac. This is the vaccine which is now replacing the earlier China-made live attenuated vaccine, and so open vial policy will be applicable to this vaccine henceforth. Question number 28. A 3.5-year-old child was diagnosed as standard risk ALL, acute lymphoblastic leukemia, and given chemotherapy. It was successfully completed over, it takes 1.5 to 2 years. When shall you be able to vaccinate the child? Because the child would already be now 5 years plus. Whenever chemotherapy has been given for some pediatric malignancy, except cyclophosphamide. Cyclophosphamide separate, but except cyclophosphamide, we keep a gap of 6 months after the last date of chemotherapy has been finished. Right? It's a fact. Some more facts taken from Nelson, OP Ghai 10th edition, and Indian Society of Pediatric Nephrology guideline putting together. This is the table. If they say chemotherapy has been given except for cyclophosphamide, vaccination should be started 6 months after the completion. According to ISPN guidelines, if nephrotic syndrome patient is on high dose prednisolone, that is 2 gram per kg per day or more, then if it has been given for less than 14 days, patient is not steroid dependent or any steroid problem, you can immediately vaccination can be done. Suppose you finish today, less than 2 weeks given, very next day you can do vaccination. But if it has been given, if prednisolone has been given for 14 days or longer, you will keep a gap of 4 weeks or 1 month after discontinuing corticosteroid. If patient has received cyclophosphamide, avoid live vaccine till 3 months. If patient has received calcineurin inhibitors like tacrolimus cyclosporin, levamisole or MMF, avoid live vaccines till 1 month after the last dose has been given. And finally, if rituximab has been given, anti-CD20 monoclonal antibody, it causes B cell depletion because CD20 is predominantly found on B cell, and so avoid live vaccine until after B cell recovery, which takes about 6 to 9 months. So these are some one-liner points you can add to your notes and revise them. Question number 29. It's an easy one. HBs AG positive lady delivers a baby. What shall be the management of the baby at birth? At birth, you have to give passive and active immunization. Both. You have to give immunoglobulin. You have to start giving first dose of hepatitis B vaccine to the child. So you will give both hepatitis B vaccine as well as HBIG. Let's review a few points about this. HBs AG positivity in pregnancy. So you will be giving both hepatitis B immunoglobulin as well as hepatitis B vaccine if the baby is born to such a lady. If pregnant mother, additionally Nelson says, if the pregnant mother has a high viral load DNA viral load is more than 2 lakh per international unit per ml, you have to give antivirals also in the third trimester like tenofovir. And ideally, HBIG should be used within 12 hours of birth. If you delay it, the earlier it is given, the better it is. The late you give, the lesser effect will come. And finally, question number 30. Which among the following is the schedule for fractional IPV in National Immunization Schedule? In 2023 onwards, Government of India added third primary dose of fractional IPV. Additionally, there were 2 doses we used to give at 6 and 14 week, but now 3 doses are given. We give it at 6 weeks. Remember, this is injectable vaccine. OPV birth dose is given, that is given. So 6 weeks of fractional IPV, 14 weeks of fractional IPV, and then also added at 9 months. 9 months. So answer to this question is D. So go through the national immunization schedule and also go through the GE vaccine, and apart from that, the basic vaccine preventable diseases. Trends change overnight, we can't say, but generally one scenario or one simple national immunization schedule based question is asked in the exam related to vaccines. And wherever possible, IAP vaccination schedule, good. You have to read some of the vaccines, you will find only there. But national immunization schedule, you cannot go wrong in the exam. So this finishes our discussion of these systems. I have tried my best not to go overboard, not to duplicate, triplicate, quadruplicate the matter, but also give you some review. And what did we gain in this entire discussion? We covered about 8 to 9 previous year questions directly, and some one-liners and some updates from the exam as well. So I hope you all benefit from it. Thank you.